Okay, so this is SOAP documentation. It is an interactive discussion with you guys, so please feel free to ask questions, offer any pertinent relative comments to the discussion. Okay, and because it is being recorded, I will try to be on my best behavior, treat you with respect and courtesy. Okay, so let's move on. Understand what you're seeing here. These presentations. This is the same presentation that I do with Dr. Fcaulty's 3709 class, which is their 9th quarter student clinic getting ready to come into CHOP. So they're getting the same information you guys are going to be looking at today. We're going to look at SOAP documentation, not necessarily exactly from the viewpoint of what we do here, as far as what the audits look at, because audits look at things more so than would be required in other circles. This is SOAP documentation by standards. We're also going to look at, remember Dr. Pryor last week segued into the difference between clinically indicated versus medically necessary. We're going to look at that a little bit deeper, just so you have an understanding and you can help the students understand this. Any questions before we get started? And I have a new laser pointer, so if you see a red dot come your way, just... Yes. Okay, everybody read this. I'm not going to read it to you out loud. Just take a moment to read this narrative description. So, this is what was written in the chart. And everybody, all right, everybody back up just a little bit. Not verbatim, but this is a typical narrative description in a chart. Okay. Now, this is what was written. Okay. This is what should have been written. Okay. Point being, and this is the first thing I cover with students, is there are things that we need to know in the patient's record. There's things that are not important. Now, what was important to know there? Spots chasing. We're observing spot chasing butterflies. Now, there were descriptions in there about the weather, with the sun shining, it felt like a dryer, towel out of a dryer or blanket out of a dryer on a cool night. Is any of that important to know? Okay. So this is what we want to impress upon our students. We want the details. And I can say this with this crowd. I said it with Dr. Fcaulty's class on Friday, and I got cows looking at a new gate. Just the facts, ma'am. Joe Friday. Okay? How many of you remember Joe Friday? You know, whenever the witnesses would get off on these tangents and start talking about all these other things, he'd pull them back, wouldn't he? Just the facts. And that's what we have to do, and that's what we want to impress upon our students. Get the information you need, but don't put in stuff that we don't need, whether it be a new patient history physical or a daily SOAP note. Just give us the facts. Okay? So let's move on. Incomplete professional languages, yes, sir. Okay, so we're going to look at compliant documentation. Just to give you the sources, these notes are a combination of CMS guidelines and also some material that I picked up from some recent webinars with ChiroCode Institute. So it's not stuff I just made up out of the top of my head. If it was, we'd have 3 slides, I'd be gone. Okay? There's other smarter people than me. This is where this stuff's coming from. But anyway, compliant documentation, what is needed? First thing, it needs to be authentic and specific. Okay? Have you ever audited any? Where's my 07 auditors? People who do the active care audits. Should be more than that. Okay. All right. Yeah, there we go. Well done. Okay, and we've added some new ones. Okay. Have you ever started reading into the SOAP notes and think, well, that just don't even sound right. Doesn't make sense. Something just seems fishy or screwy or just, yeah, it ought to make sense as you read. It ought to be authentic and specific. And this would also include any unique objective findings and subject info for each date of service. Okay. Let's say you've got a patient that you are noticing a particular thing that, you know, last few visits they tend to be walking with a different gait, favoring one side. You would make a notation of that. Even though they may not mention it, you still have an observation responsibility. What you notice to document. We'll get you paperwork. Okay. The goals should have goals on each daily visit, functional and measurable. Okay, and we're going to hear these terms over and over. This is just our introductory slides to get you appetite wet, to get to ease you into this conversation. But functional and measurable. There should be an assessment of the patient's progress in response to care. This is your proof for continuing care. You know, one of the biggest problems we have in chiropractic right now as far as the third party pays is what? Pardon?
Overtreatment?
Not overtreatment necessarily. Not underpayment. No. Well, let's talk about not underpayment necessarily, but not getting paid for what you did because you didn't document properly to justify the treatment. Okay? So, you know, we like to moan and grouse about, you know, Medicare third parties. Well, they're cheating us out of our money. Well, we know they're only going to pay what they're going to pay, but shouldn't we at least get them to pay at least what they should be paying? You know, if you think you're worth $50 a visit and they're paying $24, at least get to $24 and don't have them come back and take it back, because the number one problem the third party pays sees with chiropractic is not our philosophy, not our technique choices, not even our visitor frequency of visits, okay? But the fact that we don't properly document the why and the reasons why, and they should keep coming. You know? Anybody, how many of you in active practice or have been? Anybody ever get a letter from the third party that says, so tell us give us justification for continuing to cover this patient's visits, okay? Never got that, huh? Yeah. Yeah, every fifth visit, okay? Because they want to know, okay? You can say, and I tell students all the time, and we'll talk about more in detail on this, okay? That would be our next point. It's not enough just to say, for example, patient has a short leg. You need to document how much is it short, okay? And how much is it short on the post check, okay? Do you notice any changes? You know, I do 21st century chiropractic called activator methods, okay? So not only do we document the short leg how much, but we document position too, how much it varies, because I stress this to all my students in classes and when I talk to them in y'all's clinic classes. If I say every day the patient came in, they had a right short, and I'm out 12, 15 visits time for that reassessment, the third party's going to look at it and they're going to say, wait a minute, they're not improving because it's always short when they come in, okay? But if I document on the first visit it was an inch short, and after 12 visits it's a half inch short, and after the adjustment it's balanced, then I've documented there's progress and there's an immediate response to care. Does that make sense? Because we've got to document as much. And I say this kindly. I don't mean to hurt anybody's feelings, because, you know, I am blessed with the opportunity to read patient records every day. I see a lot of records that have minimal information, and all it would have taken was a few numbers with a parentheses beside them to give me more details, okay? And we're going to talk about that specifically, and most specifically, the patient's response. Now, before we finish today, I will hurt some people's feelings, because some of you have pet phrases, pet sentences that you like to use all the time, and some of them we're going to talk about why you shouldn't be using them. And I don't mean, if I make eye contact with anybody like Dr. Worth, I'm not talking to you directly, you just happen to be there. And these notes will be, this whole presentation will be loaded up on Blackboard under the clinic system or 411 where we have our training stuff, so you can review it later. You can download these notes. I'll probably load up the PowerPoint as it is, as well as the PDF version if you want to be able to print it or hand it to a student and say, look, go read these things. All right. So quick review of the SOAP, what it stands for, what should be in there. Everybody look at this for just a moment. The highlighted words are just things that I think are probably need to remember. You know, subjective. Everybody's got that, right? Tell me what's going on with you. Give me evaluate it for me, and that's fine. Objective findings need to be measurable, quantifiable, and observable. Okay. In other words, we see that. You know, I called Dr. Worth here back for his adjustment. I can observe how he gets out of the chair. I can observe his posture and his gait without him even knowing that I'm observing it. Okay. So, as I tell students when I talk to them, when does the objective assessment start? Thank you. The moment you look at them, you know. Look, usually they give me things like as soon as they lay on the table, you know. Well, you know, by that time they know you're looking at them, you know. I always give them a little advice on how to set up their office. So set up your office where you can see the parking lot from the adjusting room, because you get a malingering patient, they walk differently in the parking lot than when they come in their door, don't they? And we don't have them in the student clinic, you know, but you know, Dr. Merchant, he may very well have malingerers in his clinic. We may have them in this clinic. Somebody looking to get something for nothing, so to speak. Okay, and sometimes, and I mean this kindly, some patients are just nuts. That's just all there is to it. You know, I had a patient one time that, for some reason, she believed if she didn't have a short leg, she wouldn't get adjusted, and I didn't train her that. She was that way when I got her. And you'd see as the table would lay down, she would hike her left hip up till she had a 3-inch short leg. She didn't walk in like she had a 3-inch short leg, you know. And I realized later she was nuts and referred her to a colleague. So anyway, national grad, we didn't care. So anyway, I apologize. So, but you want to do the assessment as soon as you look at them and the plan. So we're going to look at this in detail. The subjective, and once again, I realize that I'm preaching to the choir, okay? But this is what the students are getting. I want you to understand, because here's the thing. I talked to the 3709 class Friday afternoon. I get back to my office. Dr. Gardner's calling me and said, you just talked to these students, and this one's telling me that you said this. So I want to make sure we're all on the same page, okay? And she was right. I did say that to the student, and okay. But students forget stuff, don't they? They misinterpret, or sometimes they just change it to suit them. So by the time they get over to the clinic, well, Dr. Guest said we had to do this, and da-da-da. So, by the way, if any of you hear anything that I said about you, it's either a lie or a misunderstanding by the students. Just so we're.
And this is being recorded, right?
It is being recorded, so please speak towards the spine stand. The patient's perspective about their complaint's condition. And when I was talking to them the other day, guess what question came up? But it's just their opinion. It doesn't really matter, does it? You can't really put any weight on what the patient says. Okay. So how do you handle that question? Remember, this is an interactive discussion. The more we interact, the sooner we get done.
Could you restate the question, please?
It's just every village needs one. It's just the patient's words. It doesn't really matter. It doesn't carry any weight. How would you answer that?
Well, go ahead, sir. You raised your hand. I did.
Senior doctor first.
Patients usually equate how they're doing or how they're responding to pain. We know that's not necessarily true.
Okay, but how do we add validity? Because it's just what the patient says.
Dr. Pryor.
Because Dr. Pryor.
The patient is the only expert on how they feel.
Good point. Patients, or as I like to say again, patients are the only expert on how they feel. Or as I like to remind them, remember the old adage, my perception is my reality. So, y'all never heard that? I hear it all the time. Anyway, so yeah, you're right. See, most of them do weigh in on pain. And I also when I talk to them about how to direct that opening statements more to how they're doing, not how their pain is. Okay? I make suggestions, and I say this to you because here's the problem. When you make a suggestion to a student on how to say something, that ends up being in every chart, like a cookie cutter. And one thing in compliance and documentation that we are being pushed to be careful of is what's called cloning, or the cutting and pasting, where every chart looks the same, So we want to be careful about that. And we're going to look at some examples of what you would write in the chart. And where's Dr. Hamrain? Okay. Go ahead and take a deep breath. Take a deep breath and relax now, okay? Because I know when we get to that, you're going to be tightened up. Relax, chill, okay? But here's the thing. Okay? Well, I don't want you to take these things and tell students, here, write it like this, because I don't want cookie cutter charts. It's just examples of what things should be in there, okay? Because of I do compliance, I get to sit in on regional meetings for compliance that are led by the DOJ. And the arm of the DOJ in healthcare compliance is the FBI. So these guys are dealing with it. And they'll tell you, we go in and audit an office, we'll pull 10 charts. They start with 10. And if we look at those charts, whether they're electronic or paper, and they have the impression that we could literally stack them up on top of each other and have everything the same except the patient name and demographics, that's a red flag, and we will be there for quite a while. Okay? You want the students to understand there's a difference between using your professional knowledge and your clinical reasoning skills to write up a patient's narrative and cookie-cuttering everything. That's why we have very limited macros in the EHR, because we don't want that everything sounds the same. We want them to think. Anybody can cut and paste, right? So anyway, but it's the patient's perspective. Let's move on. I will apologize now, because when I talk, it's kind of like being in South Georgia. We twist, we turn, we may take a gravel road, but we'll get where we're going by the time we're supposed to be there, okay? So, the subjective. What's going on with the patient? Okay? The pain. We know that's usually an opening salvo with any conversation, right? And this is where I talk to students and say, look, okay, if you want to be more wellness-oriented, more of, I'm here for the subluxation care, not necessarily treating your pain, think about how you ask the question. I can ask this patient right here, okay, how is that neck and shoulder pain doing since the last time we saw you? Or I can say, tell me what things have you noticed since your last adjustment?
My neck feels better.
Okay. He's made that assessment. He's related how his life has changed relative to the adjustment. I didn't focus on his pain. You see how that works? Now, we can get to rating that pain later, but I didn't want that to be the opening statement, because I want them there to gradually shift from pain management to wellness, and that's what we get with a lot of our students. And one reason I like to do this talk in 3709 is because a lot of them will tell me it's easy to do goals and management plan with somebody who's got a complaint. What do we do with wellness cases? What do we evaluate? How do we set? Because they don't really understand, even though that's what they want to be focusing toward. So you have to teach them how to balance. And when we get to the end of this, we're going to talk about that balancing between hang on these words, medically necessary versus clinically indicated. Okay? But pain, nature, frequency, intensity. This is where we want to throw in our VAS. Okay? What's QVAS stand for? Okay, what's VAS stand for? No, that was a trick question. VAS stands for verbal analog scale. The patient told you that. Okay? So we never put QVAS in a daily note. It's only the VAS, which is the patient's. And I wish we had another way to say it because it's confusing people. So it's not a visual analog. You're not necessarily graphing it out like the sheet where you're doing the QVAS and you've got 4 different assessments. It's the verbal analog scale, what the patient told you. So you said it got better, scale of 10, 0 to 10. Where would you put it today?
Well, I'm around a 3 today.
Actually, I'd change that. I would ask them, and this is what you really ought to do. On average, since your last visit, how would you rate it?
About a 3 today.
About a 3 today. Okay, you're still hung up on today, aren't you? But it's okay, because you want them to think in terms of, daily notes should be thinking in terms of since the last visit, not right this moment. Because here's what happens. We see things where the intern is focusing with the patient on this moment. So it's a 5 out of 10, or it's an 8 out of 10, or whatever. But then when I look at the reassessment, they're saying patient has made good progress and has no complaints. I'm thinking, well, wait a minute. The last 3 visits they had complaints, and you're telling me they have no complaints, but there's no documentation along the way to support it. Okay? This is a saga. The story's going on. We have to document it and keep up with it. Same, better, worse since last time. So this is nothing more than just having them to do an evaluation with it. But when we add the VAS on there, or whether we use the Wong faces, or the Dartmouth scale, whatever tool we're using, now we've taken that. It's just the patient's opinion or subjective comments about how they're doing, and we're quantifying it into something that we can measure visit to visit. So that was part of the reason for these oaths originally. In many of these cases was just to be able to create a quantitative, to get a consistent interpretation of what the patient said visit to visit. How's that? Give it to me. Never mind. All right, so functional limitations. how you doing every day, okay, and the patient quote. So, okay, here's an example. Now, once again, an example. I don't want to start seeing SOAP notes that have this verbiage every visit or this wording. Okay. And like I say, if you want to take pictures of the slides, that's okay, but I'm going to send them to you. So, you go. So here's the opening note, Mr. Test. Okay, and if you go to test in the live, we kind of borrowed from him a little bit. Mr. Test reports a decrease in his low back pain since his last visit and now rates it as a 3 out of 10 on a verbal analog scale. His leg pain is resolved, and he describes low back pain as tight and sore in nature. He said, there's your patient quote section right there. Okay? Okay. Resolved. And I kind of yellowed the words that I think were significant in this. Okay? Now, we could say all this without saying all this. All right? Remember the opening slide where we had that 2-paragraph, and what was it actually we were trying to see, to indicate? Spot was chasing butterflies, but we had 2 paragraphs saying the same thing. So once again, we want to impress upon our students, when you're documenting, document as simply as you need to, but as completely as you have to. Feel free to put that on a T-shirt. As simply as you need to, but as completely as you have to. Like that one. So put on purple T-shirt. Anyway, okay. So what do we know about him? He's had improvement. Okay. He rates it as a 3 out of 10. I'm assuming his previous one was higher than a 3 out of 10. And it's tight and sore. He can work, but if he works all day, he usually has to take Tylenol. So we know that he's not out of the woods yet, but he's getting close, correct? Okay, now this is the patient's perception. Any questions on subjective?
You have to quantify long day.
Okay.
So one perspective could be 8 hours, another could be 16.
I might ask him what his long day is and put it in the mark or notation in there, or maybe in the initial history. I would ask him to describe his day. How many hours is a typical day, that sort of thing.
Use it as a functional goal then afterwards, right?
You can, yeah, and that's the thing too is you want to impress upon these students. Not every goal has to have a form. Not everything has to fit on oaths. There may be something that's unique specifically to that patient that you can have as a progress marker for them visit to visit or at the reassessment. Dr. Frank, you had a question?
Just a quick question. I noticed you had to stick in what the patient said.
Yeah.
Why couldn't you have just said patient's ADLs increases pain, takes Tylenol?
Well, in documentation, they want in the subject that they want to know the patient's words as well. Okay, and here's a point, and I emphasized this with the class the other day because I'm still seeing it. Never, ever, ever, ever say patient claims. Patient states. Claiming would suggest that you have a disbelief. Okay, even if you think they're malingering and lying to you like a dog. Patient states. Let the evidence of the exam and the findings determine if they're malingering. Okay, and I'm seeing that a lot. I don't know where it's coming from, if it's coming out of a particular class or just they think it sounds more professional, say claim versus state. But when you say patient claims, it suggests that you don't believe the patient, and then it raises a red flag all over the chart. So if you're seeing that, you can't go back and change a note that's completed, but you can advise them in the future, don't use the word claim. Okay. Patient states, patient reports, okay, patient indicates. Claims just carries a negative connotation, okay? And, you may not mean anything negative by it, but it's just the word itself, And I wouldn't even say patient thinks, it's patient states, okay? So, any questions on that one? Okay. Objective, what the doctor observes both visually, clinically, or both about the patient. And we talked about this, okay? Like I say, we went down a gravel road, we got back, we're on the hard surface road again, okay? At the moment you see the patient, and I tell students, you go out and get your patient, say, third door on the right, step a few steps behind them and watch them walk. Observe them from the moment you start interacting with them, okay? So let's move on. Examine and report findings specific to each diagnosis. Measurable, observable, and quantifiable. Okay? Always remember that. It's got to be measurable. It's something that you observe and is quantifiable. And once again, here's where we have that conversation. Okay? We have our set objective things we look at. Many times based on a particular technique, there's a certain things we look at that identify this is the technique that we're assessing them with. But there's also things that we can assess with a patient that don't fit in there. Okay? For example, nut job. You know, I observed that every time this patient goes on the table, she hikes her hip up so that her leg is 3 inches short. Okay? Refer for psychoanalysis. Okay? But no, seriously. But you know, you observe that, or you may observe that. You know, you'll observe that a patient, as the high-low goes down, okay, they tend to twist because they're uncomfortable. Okay, that could be a marker that when they no longer do that, that their spine is adapting and functioning. Okay, but you're not going to do that on every patient because not every patient does that. But that may be a unique objective marker for that patient that you can document. But you have to document both pre and post and visit to visit, and to what degree. You know, just like I tell students, and this comes up a lot. Well, with activator, what do we mark? Because all we have is a positive isolation test. First thing you do is when you lay them on the table, you look how they lay on the table. Do you have a high scapula? Do you have a torqued pelvis? Okay, do they look like they've got a slight antalgic lean on the table? You document that. Before you ever touch the patient, before you even start the first isolation test, you document those things, and you document to what degree or how severe, and follow that along. Okay, patients don't even know that you're looking at that stuff. Does that make sense? If you do, for example, and I'm going to work with activator, let's say work with Thompson. You do cervical syndrome check, and the patient does it, but there's a difficulty where they're almost having to hike their shoulder up to turn their head. Document that. The first visit you do that test and they're not having to hike that shoulder, hey, you've got a progress marker there. Y'all with me on that? Is that making sense? Okay? It's not necessarily what is printed on the form. That's the problem is so many times, and you know, even with EHR, students get set, and not just students, field doctors, well, as long as we got a checkbox or something on the form, that's all we need. There's a reason why the EHR has a free form section too for those things that don't fit on the checkboxes. Somebody have a question? That's all hand. Okay.
Yeah. For measurable, where does heat, bruising, and edema fall under being able to measure? Because, I mean, I'd always report that under objective.
Yeah.
But it's not measurable.
It is measurable from your professional viewpoint, okay? And we'll talk, when we look at the example, that may answer your question, yeah. Now, you know, some people like to buy these fancy tools. You know, they say, well, patient has pain on palpation, or they want to use an algometer and say patient has pain at this reading, okay? You still know if they're fidgeting, trying, you know, if they're calling you names like a sailor on a drunken weekend, every time you palpate them, guess what? There's a lot of pain, or you're palpating really hard, okay? Anybody in here been in the Navy? Anyway, all right. So let's move on. But anyway, measure, observe, you know, your range of motions, ortho tests. Now, here's the thing. You don't do your whole ortho neuro exam every day, but if you've got a patient, for example, who has a hot low back when they come in and they can't do chems without screaming, I'm going to do chems every visit and measure that. It doesn't have to be all of them, just enough to understand what's going on. Okay? And you assess the supporting structures. This is what we do, right? Palpation. Look for these changes, look for these findings. Okay? Key point, you reference the changes relative to the last visit. Okay? Okay? It's not just what we found today. How does that compare to what we had the last visit? Not necessarily to the initial exam, but the last visit. Because daily SOAP notes are daily progression markers.
So you're saying put that in the pre-form? The
Yeah.
changes?
Yeah.
Not in the general assessment?
You
put the changes?
This is your tags for you because you're going to have to pull objective and subjective into your assessment. Okay. Don't segue me too quick into the next slide. Okay. But yeah, just you know things that you want in the objective in the free form. If it's not something that you have a check for, at least something that will trigger you. So when you do that assessment, you don't overlook these pieces. Okay. For example, well I don't know. Y'all help me out because y'all work in the documentation more. I work in the EHR side. Does the daily note allow you when you indicate short leg to indicate how much? quarter, half, or whatever? Well, that's what I'm asking. So you'd have to freeform that. You don't have, it doesn't like check off and you can pick a measurement or anything, or centimeters versus standard or anything. Okay. Okay. And this is where we dropped the ball so many times in the 07 audit. Any complaint documented in a prior patient encounter must be documented until it's resolved. And like I tell students, it doesn't have to be 90 days resolved, okay? But it has to be documented. If it's in the original history as a chief complaint, yeah, we may need a 90-day. But let's say, I'm going to pick on you for a minute, okay? I did this the other day. I kept using a student. I turned around. He was gone. He left. I don't know why he left early, but anyway. Dr. Bravo comes in today, okay, and say, how you been since the last adjustment? Okay, but I got this, headache going on. I said, and he didn't have headache on his original report. Well, why do you think that's happening? Well, I've been up studying a lot for midterms, that sort of stuff. I usually use this example with students. I'm just kind of stressed. Okay, I don't need to reinvent the wheel with him. I don't need to throw him into a whole headache disability index or anything like that. He's quantified it why he thinks it's happening. Okay. Now, if he said, well, a brick fell off the window ledge upstairs and hit me in the head, now we got to rethink it. But there's no reason to reinvent the wheel on this. Say, okay, give me a rating on it, and we're going to keep up with it. Next visit, how you doing? Okay, how about the headache? Oh, it's gone. I got a couple of nights rest, and I'm good with it. Okay. Then we're done. It's resolved. Okay. But I still got to track it until I got an answer. I used to say, and I tried this Friday, it didn't work, but I'm going to try it now. It's a soap opera. Remember in soap opera? Anybody ever watch soap operas besides Joyce? Okay, remember once you did. Once a storyline was introduced, it stayed in that soap opera till something happened, right? Same thing. It stays in that narrative, that storyline until you can give an answer for it. Okay. Now, if it's something that's, as in this example, well, I was studying for midterm, blah, blah, blah. When I know it's finals week, I may ask him, how you been doing? Any more headaches since you're studying more? Okay. See if that's something that he's just, we may have an issue. Maybe he's got eye strain, and we might make a recommendation. Maybe you need to get your eyes examined.
So this is a difference. This is a scenario where you're just monitoring it to determine if it needs to be diagnosed, because once we diagnose it, at least as far as the clinic policy, that remains for 30 days. Right?
Well, we're talking about what the school requires and what you would do necessarily out in practice, because we are stricter here. Okay, we have a lot more requirements just because we're an educational institution. We require that our students do more work than they would in not real practice, but in their own private practice, because we have a teaching aspect to keep too. But you evaluate it as the faculty clinician. You and the intern evaluate it and say, well, this isn't something. There's no red flags going off. There's no alarms or whistles. We can just watch this. Okay, you can diagnose it on that visit if it stays consistent, and this is where your professional judgment comes in. You may have to decide, okay, we need to do a more extensive evaluation. Does that make sense? Okay. But if he said, well, I just didn't get good sleep, we can just notate it and not even have to do anything other than. And once again, we'll hold on that question until we get to the diagnosis, the medical versus clinically diagnosis page, okay? That may answer your question. Any questions on this saga? Okay. Y'all don't let me lose track of time. Okay. Okay. All right. This is where your part's going to come into play. I asked the students the other day, and this was Friday, I said, how many of you are familiar with PART? Now, they are in 9th quarter. So they're in their second student clinic quarter. Nobody in the whole class raised their hand. Said they'd never heard of PART. I know they lie. I just didn't tell them to their face. Speak towards the microphone when you say that, please. No, but the reality is they may have seen this but not understood the mnemonic for it, for the PART. But this is Medicare's guidelines, right? Remember, those of you who are old enough when Medicare required x-rays but wouldn't pay for them? And then they said you don't have to have x-rays, but you got to justify the subluxation. This is PART. And I tell them, and most of them, when we covered this, they realized, oh, well, we do that. They just didn't know it was PART. Okay, it's the PART. And I know that most of you, I've been in the student clinic, most of you have this list stuck up on your wall over your desk. Okay, they're just not observant. Okay? You might want to, every now and then while you're doing a CMR, say, look, part. Remember that? Because they're going to get asked, they're going to get letters from Medicare saying, do you have part documentation to support your diagnosis? Well, we'd rather they not look at the auditor from CMS and say, what's part? Right? Okay, so anyway, and remember, and this comes up because I've answered 2 questions just last week about this with faculty doctors, okay? You got to have at least 2 of the 4, and at least 1 of those 2 has to be the asymmetry or range, okay? They don't have to have pain, okay? They don't have to have tone tissue changes, but they do have to have at least one of them either has to indicate an asymmetry, and as let's ask them pray, what's an asymmetry? Listing, okay? Or a range. They don't have to have both. Although in my mind, I'm kind of like, well, how'd you determine the listing without there was a restriction in range? But they could say, you know, and come skin. And one of them say, well, I'll just take it off the x-ray. So, well, part was meant to be used without x-rays, you know? So, but, okay, do we assess pain every visit? Not necessarily. And this is where the conversation with students gets fun, because now they start realizing I can have wellness case. I can document just as good as any other case on a wellness case, because they just don't quite understand. Well, if it's a wellness case, that doesn't require much documentation. You know, and that's when we have, you know, the mommy and daddy stare. Really? You know, y'all done that? You've been there? You know, okay. No, because we explained to them, I don't care if it's a wellness case, if they got 12 complaints. Documentation standards are documentation standards. You may not have to write as much, but you still have to write what's necessary.
On EHR for activated safety instrument adjustment, so I don't feel like that's always addressed.
What's not addressed?
Part.
Yeah. We still got the free form.
Are they taught to put that in the free form?
I was just told that they were liars because they didn't know part, so I'm assuming they're being taught somewhere. Okay.
For what is that?
For documenting part. Okay.
Oh.
Yeah, and I'm a sidebar for just a moment. There is a problem that we have in the perception with activator, okay? In that their perception is, I just do activator because it's just checking off. I don't have to do all the other work that I do with these others. And that is a lie from the depths of technique hell. I don't know where it came from. I don't know why they think that. You know, it's just like the whole thing, well, if I do activator, I don't have to do x-rays. No. Every case requires a valid history and the appropriate exam based on the case, regardless of whether you're doing HIO, you know, toggle recoil, you're doing activator, you're doing Gonstead. None of the techniques that we teach here preclude a valid initial exam. Does that make sense? You know, and I tell students all the time, I don't care if I'm just, well, I don't know, you know, well, we don't do Logan here, but even that, if you suspect that there's something pathological that X-ray would reveal you have an obligation to rule it out. Okay, so, and I hear that a lot. I get it. You know, well, I'm gonna do activator that way I don't have to take X-rays. I don't know where that came from. It's never been activator's viewpoint. It's never been any technique viewpoint to shortcut the exam. Okay? So, anyway.
With the part and activator, since I do a lot of activator in my practice too, can we consider when you do an isolation test that is a misalignment and a range of motion issue, and when you have a finding from an isolation test?
The isolation test indicates and I don't want to get too in the weeds on one particular technique, is that there's a segmental dysfunction. Position 2 indicates that there's an asymmetry in that position. Yeah. But once again, you know, let's say I'm using Thompson. Okay, cervical syndrome indicates that there's a dysfunction. When I go up and if you do it by the way Thompson said, and I palpate and I find that tender nodular, the P, there's my tissue tone pain response. Okay, and understand this, when we talk about the pain, guys, it's not necessarily that the patient came in and said, I have this pain. The patient says, I'm fine, I feel great, and you're palpating, and they say, well, that hurts. That's your pain. They don't have to present with it. You may discover it. Y'all with me on that? Okay. And, you know, here's the thing. We do part every day, don't we? if we're doing any type of halfway decent spinal exam before we touch the patient. Dr. Jim?
We're doing part,
Mm-hmm.
but as far as EHR is concerned, we're not documenting it. For instance, in Thompson, when you do your palpation, you do one segment palpation.
Okay.
Cervical. That's all. There's supposed to be two.
Okay. No.
Either an A or an R and a P.
Okay, but okay, if I do Thompson, we'll use that one. What's my justification for adjusting the cervical?
It's a tender nodule.
What else? I don't just go feel the tender nodule. I check the legs. That's my posture analysis. I have a cervical syndrome. That's my segmental dysfunction. Okay.
I agree.
Okay, and then I go up and validate it by that tender nodule. There's my pain response.
But it's not being written down.
Oh, well, now if it's not being documented, that's a different story, because they should be, and here's the problem, they should be documenting patient had a positive right cervical syndrome, palpation revealed a tender nodule at C2, C3. Well, then they are writing it down. That's documentation.
Okay.
We've just,
That's free-forming and the...
yeah, we've documented dysfunction, a regional dysfunction or asymmetry, we've documented, and by nature of what we're doing, we've assessed that because they have this and this, there's a segmental malposition of the vertebra. Now we've documented our asymmetry. Okay. Now, that's what I'm saying. We do this, we just may not recognize it or realize, and we're documenting it, we just may not realize we're documenting it. Okay? Yes?
On pain, my understanding always for objective pain is it has to be in response to palpation.
Yeah, but
For objective.
for the objective. But if they come in with a pain response, then that supports that as well. Okay? But you should be able, here's the thing, patient says, well, I got this pain. Theoretically, you should be able to replicate or elicit that pain, And that's one of the things that we do, just like with the Hoovers or some of these other malingering ruling out tests, helps us to quantify that subjective complaint with an objective assessment too. But yeah, Dr. Bravo comes in and says, well, I got a pain here in my neck, okay? And after we've assessed that it's not a work colleague and that it's a true physical pain, then I'm gonna look and see if I can replicate that. If I can't replicate it, I'm gonna ask him what provokes it and ask him to repeat that movement. And you're like, well, when I do this, okay, do that for me now. Is it still? Yeah. Then we've replicated it either through palpation or his active motion. Does that answer that question? This was supposed to be the quick slide, but anyway. But especially in the CC hop where 99.9% of all patients are well in this case, this is their slide. I mean, this is where they need to be. They should be experts at documenting this. Okay? Okay.
So on this,
Did it back up? Yeah, okay.
again, I'm going back to interactions with some of these students in 8th and 9th quarter. On the last sentence, we documented the amount of degrees of decrease in lumbar extension. Why aren't we documenting how much spasm, edema, because we're saying it decreased.
Yeah.
We're saying the asymmetry and range of motion restricted noted L305, but we're not documenting the degree of change on the first part. Why?
The degree as far as the edema?
Yeah, because its finding has decreased since last visit, so...
Well, I guess you could say by 50% or something, but we don't.
Some sort of
We don't have anything.
quantification of it.
Yeah.
We don't want
Well, yeah, you could. I mean, you wouldn't be wrong to do that, but you'd have.
But right now, we just do mild, moderate.
And that's fine too. Mild, moderate, severe are acceptable terms. Okay, so patient's pain response on palpation is mild, and you look last week it was moderate. So those are acceptable terms. And one of the key points I wanted to point out on this slide, I'm glad you made me go back because I forgot this. This word right here. Active lumbar extension is observed. So you've quantified the evaluation method versus using a... All right, I went to Sherman. I don't know what we use. Goniometer? No, inclinometer. That's what I knew. I knew it was hanging out there somewhere. All I could think was subluxation station. The inclinometer, or whatever tool you're using. So, and that's one of the things you have to do when you write your reports is, it's not enough just to say patient had a high shoulder, high hip, based on SAM unit or based on whatever tool, based on whatever. I know we have some posture software now, apps. If you're using a particular software, a particular app, where you're taking a picture of your patient and it's doing a posture analysis. In your notes, you need at least, maybe not necessarily daily notes, but at least in your report writing, you need to include the method that you use to do it. Observation, eyeball, or SAM unit. Anybody ever read a medical report on a surgery? I mean, we're talking about the size of the needle, the type of silk, the thread they used, blah, 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 blah. I'd puke if I had to write all that over the mic. But we don't write enough. That's the problem. Dr. Frank?
Last question, Doc. I don't know if you get a chance to analyze in your objective note.
Mm-hmm.
And my thing has always been to them, did you measure? No.
Yeah.
How can you use it? You got a range of motion restriction. You're not saying which plane.
Well,
where would that go?
Yeah, we're teaching.
okay, so maybe that could have better notes. And that's fine. Yeah, I take that. Okay. We've stated how we did it, you know, and here's the thing. Observation is an acceptable form. It may not be considered as valid as inclinometer, but, and here's what I want to stress upon the students. If I assess Dr. Wilson's range of motion last visit with an inclinometer and I do it this visit observationally, I don't have any valid findings because I changed the tool, changed the method. Same thing. When you go, if you do a Oates QVOS on a complaint on the first visit, and then you do, as a net complaint, and you do an NDI on the reassessment, that's worthless because your pre and post and your assessment tools have to stay consistent unless you determine that the tool you used is not valid and you document that you're no longer going to use that tool and you're going to move forward with this tool and why. Everybody with me on that? Terry, then you.
So we're talking about two different things, right? For part, we have to have motion restriction, that's something that's segmental. But now we're talking about measuring active range of motion.
The range is both segmentally or global.
Or global.
Or it can be either or.
But it doesn't have. There doesn't have to be a global range of motion.
No.
Okay.
And this is where I tell them, say you want to tie in your inclinometer readings with your MOPAL findings. You can be either or both to substantiate it. Okay. Because MOPAL is that looking at lateral flexion segmental restrictions. Okay.
Which goes under the asymmetry misalignment.
Yeah.
And that's where they're getting confused. They think that range of motion goes under their motion findings, and they'll put decreased range of motion, and we have to correct them and say, no, it's restricted movement. It's segmental versus global.
Asymmetry is the asymmetry is your listing or your malposition of the vertebra.
They're getting a listing from their motion.
But you can't just say, well, you're this listing. You got to have the support for that listing.
Flexion, extension.
Yeah, range. Yeah.
But they're confusing range of motion, the R with the A.
Right. So you see why I could take a wellness case, take a subluxation perspective, and build my whole documentation on A and R. I don't ever have to discuss pain. I don't have to have pain, and that's why P and T are not required. One of the other two are required.
So just throw observable ROM into the freeform, correct?
Could, yeah.
Let it go with that?
Yeah. Yeah, I understand this, guys. Anything that you, and Dr. Pryor, here's where you want to correct me if I'm wrong. If it's an observation of the patient that is abnormal or aberrant, and it doesn't have a check, throw it in the free form. And then you and your clinical doctor, and now I'm talking to the interns. What I tell them, then you and your faculty doctor can look at it and decide whether or not it's relevant to the case, and it needs to be tracked visit to visit. How we doing? Joyce?
So in the EHR program, there's restricted motion, aka when there's another one, joint fixation.
Once again, I don't work on the documentation side. I work on the finished product side. So, but if there's a way to document that, yeah. Same thing. When you're going in there and you're doing those ranges and you go in and click left lateral flexion, you've got that little scale where you can slide it over to what your range is compared to normal. In that free form, you need to state how you did that. Observe or whatever. Okay? Booch, slap shark. She's having trouble staying awake. Okay. The assessment. Any more questions on the objective piece, the part? We good? Because I don't want to leave you behind, but we do have a deadline. So anyway, the doctor's determination about the patient's progress. Does it say every comorbidity? if it has an effect on the patient's response to care or their progress.
So,
Breathe.
for every assessment,
Yeah.
you want us then to say something about their IBOC or their fundamental diseases, or, I mean, that all affects care, their progress. You want
Well,
to mention
things like IVOC are fixed. They're not going to. We're talking about things that could have an effect of really. Breathe, relax. I knew this was going to get hairy for you. But we're talking about things. We're talking about things that could progress, could change. I'm going to use myself as an example. Okay. I have a lot of metal and prosthetic hip. I have foot drop. It's there. It's not going to change. That's a comorbidity. It's a complicating factor. It's only relevant if it's causing me not to hold my adjustments. It's not relevant to anything because we're not trying to manage it. We're not trying to treat it. It doesn't need to be mentioned visit to visit. Okay? Does that make sense?
So, the only reason we would mention that is if we weren't doing adjustments, but you can't be sure that's why you're not.
Okay.
So, can you give me a better example?
So we're not managing and tracking this. It is what it is. Okay. But last week I cut grass. Okay. I have a hilly yard. So because I limp and I don't have a lot of support there, I tend to always need to be adjusted come Monday morning. So in that case, you would relate that to. Does that make sense? And I don't like using myself as an example, but it is what it is. Okay. So I make sure that my intern knows. Put down what my weekend activity was and how it has affected my posture and all that, so that he can evaluate whether or not that has any bearing on why I didn't hold my adjustments or why I need to be adjusted this time. That's those type of things, okay? So on a day in, day out, when I walk on floors like this, it doesn't affect me. But the condition connected with the activity I did, now it has a negative effect. Does that make sense? Okay, assessment is not a diagnosis list. Okay, and I hate to do not statements, but I just don't know how to word it without and get it in a list. Okay, it is not patient feels the same. By the way, the first one I pulled from the Cairo Code webinar. The rest of them I pulled off our files. Just so you know. Wait a minute. Are you reading down the list? Okay. Patient feels the same. Intern will continue patient care plan to work towards goals. First off, what's wrong with patient feels the same? Same as what? I remember the first doctor I practiced with, a lovely man, wonderful chiropractor, had a cradle-to-grave practice. He loved his patients. They loved him. I just got an email from his wife last week. They're getting ready to celebrate his 40th year in practice, and they want everybody to send a letter, card, or something. Great, wonderful guy. But he had the old Parker forms, the travel cards, and I can tell you that probably out of 20 visits on a side, at least 10 or 12 of them had the same diagnosis, SAME. I was in practice with him for a while before I realized SAME was not a diagnosis. It was. I asked him one day, I said, "What's the SAME stand for?" Same thing as last visit. You know, that was his whole documentation. You know, he meant well. He just wasn't. You know, great adjuster, great guy. You know, great philosophical background, belief. Well, I did the same thing as last time. I just write same. Okay, and that's the kind of documentation that gets us in trouble as a profession, as individuals. Okay, patient feels the same, and I used to pick on students. I'd say, so Dr. Bravo, you said this patient feels the same. Okay, or you said they feel fine. So did you hold them? Did you caress them? How did you determine that they felt fine? Okay. At least say the patient states they feel fine, not patient feels fine, because I know I'm being facetious, but how do you read it? You know, what is. Okay, so intern will continue patient care plan to work towards goals. That's not necessarily all bad, but what's the goals? State what the goal is. Okay, intern will continue patient care plan. I would probably change that to, well, number one, what the intern's doing is not part of the assessment. Okay, that's what the intern activity is. That has nothing to do with the assessment of the patient's condition or complaints or progress under care. Okay, so there's a lot of things wrong with that one. Patient is improving as expected. Great. What's expected? They improve. Yes. Okay, and once again, my favorite. Same. Now, honestly, Same I just pulled out of my history, not out of our charts. We do not have any charts that have same on them, okay? Okay. Dr. King was getting ready to send a text to Dr. Lavender. We're going to fix these charts right now. Sorry, wrong button. Patient is responding favorably. Okay. As evidenced by. So we made an assessment of how they're responding to care. We're giving the evidence to support that. Okay. Now, this particular case, we had a lot of stuff going on, so we got a lot to write. Okay. Not all of them are going to be this much. Okay. Here's a note. Y'all remember when we talked before, I think last year we talked about, I went through the audits and told you on each of the audits what was the number one question or the number one reason why questions were missed. I prioritized them by this question is missed most often because of this item. Do you remember what the assessment question was? Why it was marked no on the audit the most number of times? Why do I even teach you if you're not going to remember? It's a struggle, I'm telling you. No mention of the progress of the chief complaint. They tell me everything and anything about the patient, and never mention the chief complaint. Not that we want to focus on that, but that ought to at least be your opening statement. Okay? Patient's chief complaint is responding, and what's your evidence that they're responding? You can't just say that it's responding. How do you know it? How do I know that it's responding based on what you're writing? Remember this. Remember we talked before about the third eye? When you write your notes, always think in terms of that third eye, or that other person who knows nothing about the case should be able to read your notes and understand everything that's important to understand about that case. Okay? And like I say, guys, I'm telling you guys what I tell the students. I'm teaching you as I taught the students. If I can't pick up that chart and read those daily SOAP notes and understand that to the same degree that you do, something's missing. And I'll talk to students sometimes. I'll say, I don't quite understand this. Something's not. What's happening with this with the patient? Oh, well, they're doing this, blah blah blah. Well, how do I know that? Well, we talked about it over the weekend. They called me. I said, it's not in your chart. Just if it's up here and it's not in the chart, it doesn't count for anything. Okay? Because the interns will know a lot about their patients because they dialogue with them, they talk to them, they whatever, but it doesn't get in the chart. And they say, well, yeah, I knew that because of this. If I can't read it and know it, then there's something missing. Does that make sense? If I can't read it and know the same thing about the case that Dr. Hamilton knows about the case, and that's how auditors look at it, I should be able to read the book and know it to the story just as well as you know the story. Sorry.
Yes, with this assessment, and I know I sent you emails on this before, this is the biggest piece of the assessment puzzle that the students don't get. When are they actually learning this? Are they learning before they go into CC Hawk?
Dr. King?
Because they're coming in and we're going to teach
I don't answer curriculum questions because I only teach 2 labs and they have nothing to do with this.
You're saying it's in ninth quarter.
Let me give you a theoretical answer.
Right.
They're learning it in every class that it requires documentation or every technique class where they're documenting. It's reinforced throughout the curriculum. It is. I mean, that's theoretically. So they may not be getting this in a box in one class, but it should be re-emphasized and enforced in every class where they're doing any type of documentation.
They're real good about discussing the subjective side, but they can't get the objective side.
Yeah, I keep pointing to Dr. Clustrat, but Dr. King keeps intercepting my point. So, yeah, they should be getting it. But once again, guys, and let me say this, and I'm going to say this kindly. I don't mean to sound harshly, okay? You guys are teachers too. If they're not getting it, reinforce it to them. That's why we're doing this training, so that everybody is on the same page. The classroom and the clinic should be on the same page on all these things. Okay?
Whenever there are workshops that are given to clinic faculty, we need to be aware of what's being taught in the clinic versus, what's being taught in academics, so that we can have that congruence across the board. So I'm definitely learning a lot here, and we'll be going back to it into the curriculum to see if we have any gaps.
How many people are on the subcommittee for the curriculum review and revision? All right? Pay attention. These are the issues. These are the things we're looking to improve. All right?
Okay. And understand this too as well, guys. Okay. This same stuff, these trainings that we're doing, they're going to be available to classroom faculty. If they want me to come do trainings with them face to face, that will happen. Okay. There are no silos on this campus. We're one big stadium with the same team. Okay. For the Olympics. Okay. Dr. Vanderslice and then Dr. Sayers.
So in full spine 3, the full spine instructors on the didactic side have me write on the board what we want in the clinic on the assessment. So I write down 4 or 5 things, topics that they need to use as a template to start working on this, and that's the first time, my understanding from feedback from the students, that they've seen it put together here and where that goes. I'm just telling you
Yeah.
what was said.
Okay.
So if this would be helpful to get to the full spine lab instructors and the lead to give them this information, what we expect in the clinic, so they can reinforce it in their lab.
Okay. And let's just say it'd be helpful if everybody had the information. Okay. And that's one of the, to me, that's one of the advantages of having clinic people doing some of these labs, is we're able to share the information. And but once again, we share in a professional, helpful way, not in a critical way. Did I say that right? Yeah. Because you know me, I don't like critical. Dr. Sayers.
Doesn't one of our audits say that we have to mention compliance at least 50% of the time?
No. None of our audits say that. Are you talking what?
In the daily notes, the 07 audit, the question about assessment does definitely ask about compliance.
Compliance at least 50% of the
Okay.
whole file.
If they're not there, why?
But but it's not saying you have to say the patient is compliant. You're evaluating the patient's compliance with the care plan.
You're looking for documentation of why they weren't compliant.
Right. And if they're not, but that goes to the number one reason why the plan is marked wrong on that question is marked wrong on both the 11 audit and the 07 audit, is because there is not compliance with the care plan and there's no documentation to say why it's not. Okay? And to just say patient is not compliant is not enough. Patient is not compliant and hasn't returned phone calls, it's a little bit better. Okay? Because if you say patient is not compliant, I don't know why they're not compliant. Nobody else does.
Sorry, that you would do for a reassessment because it is lengthy. You wouldn't do this every visit.
No. And a wellness case, you wouldn't get anywhere close to all this. Achieve complaint. This is a big example. Okay. But once again, I would look at this and say, okay, I'm evaluating Dr. Bravo today. What do I need to say relative so that I would at least have the same understanding? Okay. And what's the key point? I got his response. Okay. As evidenced by. Okay. And based on this, he still has these findings, and therefore he's making progress, but we still have a need to continue care, to continue progress. Okay? Take this and put it in your own words, how you're comfortable with it, okay?
Yeah, so there seems to be this understanding that by the students that they need to say the patient is compliant pretty much on every single note.
Yeah.
And so when I tell them it's really not an issue unless they're not compliant and you are seeing problems based on their lack of compliance, but they don't really need to state every
They don't have to
time.
state it all the time. No. And I can look, if that's the way you guys are reading the questions that way, I can look at the question, because to say you have to state compliance 50% of the visits, there's no magic number for that. They are or they aren't. And one of the ways that we evaluate compliance, and I need to move on from this, is we look at the care plan, what the recommendations were, and was that followed. If that's followed, they're compliant. Okay. If you're giving them at-home exercises, they're doing them, they're compliant. So it's not enough just to say the patient's compliant. There better be evidence in the file to support that they're compliant. Okay. The diagnosis must be supported by history and exam. This is the guidelines. Okay. And this is where we're going to come into some of the other stuff that Dr. Pryor wants to get to, and I know we're getting short. What's the patient's response? Can I move on from this one? Okay. What you did, how you did in response to the patient. Once again, pre and post. If you've got objective findings that you used in your clinical decision-making process to determine this patient needed adjustment, I need to see those in the post too. And here's the problem. I'll look at charts and we'll have 4 or 5 things that says this patient has and they don't say it in this way, but this is what it's saying. This patient has exhibited clinical evidence of a subluxation based on this criteria, and I look at the post-check and I see balanced legs. What about the other 4 criteria? If you use it to make a decision to adjust, you need to reevaluate it on the post. Does that make sense? Okay, and that's the problem, and I teach this to students. I teach this because I give these talks to other chiropractors, other places. Problem with chiropractors is we tend to find 1 or 2 shiny, bright objects we like and hang our hat on that all the time, and we don't look at all the other things. Okay, and I don't mean that derogatory. I was the same way in practice. Okay, so specific. So, any services, any ancillary missed or rescheduled appointments, any conversations, patient calls, patient sends you a text, and that's a whole other ball of wax we need to talk to at some point in time about use of email and social media and texting, but we're working on gathering the details because there's been a lot of HIPAA's in a flux right now on that stuff because nobody's really sure how to lock it down or not lock it down or what you can and can't do. But fortunately, I've had the opportunity to do several webinars this month alone on those type of things. So we may actually have something in the spring on social media use with patient records, that sort of stuff. We need to. Did I go backwards? Attention, or maybe I duplicated the slide. Here's the example. Let me say this. I know philosophically there's going to be some terms in here some of you don't like, but deal with it. Okay? I know, Steve. I can see the pain. It's hurting you already. Okay. Give me a minute. Give me 2 minutes. Does everybody do the surveys? Make sure I get them before you leave. All right, L5 and sacrum following adjustment. So what do we have? What was done, what technique, and in the side posture. And here's why this is important. There's more than one way to adjust the lumbar spine in Gonstead technique, correct, Dr. Tomasello?
Yes.
Okay. A patient may do well with one way and have an adverse reaction to the other. If we don't document how it was done and what the response was, and you as the intern go on vacation and somebody else covers for you and adjust them in the way that they have an adverse reaction to, we got liabilities, we got negligence, we got patient pain. Okay, so it's important. Okay, just like when I document an activator case, I document the setting on the activators because some patients respond better to lower, higher settings. Does that make sense? Not just enough to say activator. Manual therapy, lower left. Okay, we can just skip that paragraph, Steve. You feel better? So let's move on. Any questions on that? All right. This has come up. So, actually, Dr. Pryor, are you talking next week?
Yeah.
Let me pause here. Can I have a little bit of your time to start with next week to finish up these slides? Is that going to? Because I don't think you're going to need the whole time, right? So Dr. Pryor has CE next week, and he and I knew that we might have to dovetail on each other. So I'm going to pause here. There's these burning FAQs. We'll stop here today. I'll open up next week, and then he'll finish up. Fair enough? Make sure you get your forms. I need the sign-in sheet and your surveys, please. Huh? I suggested, let me just put it all there. I'll take it all.